Thank you. Well, good morning, everyone. It is with really great pleasure to introduce Dr. Josh King. He's actually only one of three medical toxicologists who comes from a nephrology background. He did his medical school at Penn State, did IM and his med tox fellowship at UVA, where he was also a chief resident, and Hopkins is where he did his renal fellowship. He's also the medical director of the Maryland Poison Control Center and the program director of the Nephrology Fellowship Program. He's additionally an associate professor of medicine and pharmacy at the University of Maryland, Baltimore, and he's on the board of directors at ACMT, which is the American College of Medical Toxicologists. He's an amazing clinician educator, which I myself can speak directly to, and he's received a number of educational awards, all while managing to see patients and be the program director, as noted before, of nephrology and medical director of the Poison Control Center, and still does a bit of research and split his time between tox and renal. So thank you so much, Dr. King, and welcome.
No, thanks so much, Dr. Berlin. Thanks, Dr. Weiner, and everyone for having me here. I'm going to be talking a little fast. I would love for everybody to get these slides if they are useful to you, and if they're not, please throw them away. I'm going to throw some tox flavor into this, but this is mostly a hyperkalemia talk. I was going to be there in person, but then the ACGME came to town and it did not happen. So unless you throw me out, I'll show up at some point. But let's talk about hyperkalemia real quick. I would treat any K above 6.5 the way you usually do. But I want to talk about potassiums that are high, but not that high. Just to give you some practical thoughts as to what to do. And bear in mind, I'm a nephrologist, right? I am biased as to what I see. Same for tox. So, my presentation is going to reflect that bias. You might see stuff that I do not. But let me tell you about my first scary hyperkalemia. This is when I was an intern, had a patient who had acute heart transplant rejection, oliguric, had a dialysis catheter placed. Her potassium was 6.5, and we were getting ready to dialyze her. And then the nurse calls me over, and her telemetry looks like that. And it rapidly went from that to a blood pressure of 40 over nothing. Calcium gluconate got pushed, and I saw those sine waves narrow in real time. In other words, calcium does actually work, but it works when you push it. So that's scary hyperkalemia. Hyperkalemia is really common depending on your patient population. If you don't have kidney disease, it's not that common. If you do, it's pretty common. And if you have end-stage kidney disease, it's most people. So we see it all the time. And I'm sorry, you miss this stuff, right? Everyone loves a nephron. Sure you do. And you'll remember that most potassium is absorbed proximally, then some of the loop of Henle. And then if you have high potassium intake, your distal tubule and your collecting duct starts excreting potassium. We can get rid of 80% of the potassium we take in. Or if your potassium is low, our kidneys can reabsorb 99% of it. We can reabsorb a very large amount if we need to. So you have this huge variation depending on what your intake is and how well your kidneys work. There's several categories of high potassium. And I'm going to go over them quickly because I think you know them all, right? One of them is just having potassium release, rhabdo, tumor lysis, tissue death, maybe having shifting, right? So non-get metabolic acidosis, your patient has, say, diarrhea or an RTA, insulin deficiency. You see this all the time in DKA. You start them on insulin and their K goes from 6 to 2.5 and you say, what happened? Beta blockers tends to cause a very unimpressive shift. Succinylcholine really only causes an impressive shift if your patient's deconditioned. So in the ED, unlikely. In the SICU, on your SICU rotation after 3 weeks in the hospital, you probably shouldn't use it because I have seen dangerous hyperkalemia in that setting. We'll talk more about sodium potassium ATPase inhibitors like digoxin. That can cause K, which is dangerous for different reasons. And then getting rid of too little potassium. Mostly your kidneys aren't working, or you're on diuretics that don't let you do it, or you have weird genetic stuff, or maybe ACE inhibitors. And then, of course, you can always take in a lot of potassium. And we do see potassium chloride overdose in toxicology, right? If you ingest 40 tablets of potassium chloride, your K can go from normal to 8 and then back to normal usually quickly, hopefully without arrhythmias along the way. But hopefully, Hickham's dictum, right? The patient can have as many diseases as they darn well please. You can have more than one of these. And usually patients with significant hyperkalemia, in my experience, have more than one of these. Here's another potassium story for you. I was first year renal fellow. I had a patient who was on the larger side and who ate a high potassium diet, lots of green leafy vegetables that are high K, lots of meat and dairy. Dairy is very high K. He presented with weakness, a potassium of 9. This is your obligatory frightening hyperkalemia EKG, right? You are all familiar with the widened QRS, the long PR interval, maybe P waves disappear, your peak T's, and the definition of a peak T wave is, it would be uncomfortable if somebody poked you with it. So that's a peak T wave. This is what this patient's EKG looked like. It was completely normal. And he got calcium, he got insulin, the EKG didn't change. He got dialysis, his potassium went down to 4 or 5, and his EKG didn't change. So there's a real difference if you have chronic hyperkalemia. And I want to try to give you a framework to deal with this because there's a lot of patients who will have hyperkalemia and no EKG changes. It doesn't really start to make much of a difference till your K is above 7.2. And even in end-stage kidney disease, you can get an EKG and be like, oh, they got a peak T, it's going to have hyperkalemia. It doesn't predict it very well. And those patients are used to hyperkalemia. Their cardiac membranes see it all the time. They don't respond as much. And you can undoubtedly find lots of these different graphs. You can look at this later, but all of these graphs basically say your mortality is lowest with the potassium around 4. And if you're lower, it'll go up. And if you're higher, it'll go up. And there are lots of these graphs. So when is hyperkalemia dangerous? One thing, it's dangerous in acute illness states. It can be dangerous in heart failure. And the problem is, how much of it is association versus due to the hyperkalemia? Because if you treat that hyperkalemia, it's not as well associated with improved mortality. So it's bad, but you can't necessarily fix the bad. So what do you do? It's not really clear how much of it's associated with arrhythmias. So I want to show you what I do in a minute. We do have other evidence that it's bad. If you look at patients getting dialysis and you look at their heart rates on the 12-hour interval before their next dialysis, they are much more likely to have bradycardia. So we know there's some potassium effect there. We also know that a large percentage of patients you see with end-stage kidney disease, like 8%, have 8% prevalence of hyperkalemia. So if you see a patient with end-stage kidney disease, 8% of them are going to have a K above 6, and roughly 40% of them are going to have hyperkalemia when they come into your ED. And it's associated with increased risk of death, but it's not like it's dramatically increased, right? A K above 6, 12% higher risk of death. You'd think it'd be higher, but no, it's only 12%. They do have a 20% greater risk for arrhythmias, so there's something there. And then we can also look again at times before dialysis, and we note that basically after that long stretch, that 72 hours, no dialysis, you are at your greatest risk for arrhythmia. So you could blame a lot of that on potassium, and you probably would be right there. And then you can also look at the so-called Brash syndrome, where if you have a patient, and you've probably seen this, if you have patients on beta blockers who are also hyperkalemic, the hyperkalemia and the beta blocker essentially combine to cause worsened bradycardia, and the worsened bradycardia makes their kidneys more unhappy, and this worsens their kidney failure, and this worsens their hyperkalemia, and it goes from there, right? So you can have that scenario too. So let's give you one more case, and then I'm going to give you that framework that I've been teasing at. This is after I did my internal medicine, I did my renal fellowship, and now I'm coming back as a tox fellow. This is like month 1. And we had a 40-year-old who presented after drinking wheel cleaner, which contains hydrofluoric acid. He gets intubated. He has moderate hyperkalemia. His K is 5.7. And his EKG looked like this. Pretty scary for a K of 5.7. It had notable QRS widening and QTC prolongation and other abnormalities. And the reason it had that is because hydrofluoric acid will bind up calcium and will bind up magnesium and will also block the sodium potassium ATPase. So that potassium wasn't because the patient was generating more potassium. It's because his sodium potassium ATPase was blocked, as well as probably some other channels. And he comes in and we give him calcium and magnesium. We fix his QTC and we say, oh, good, he's not going to have torsades. But he went into VFib right in front of us and we were not able to bring him back. And this is when I learned how dangerous hydrofluoric acid was. And it's also when I learned, sometimes that potassium is a marker of something much worse. And that's the hyperkalemia. That's one of the hyperkalemias that I want you to know about to be vigilant for. So this is, I'll take a couple minutes on this slide and similar ones. This is a rubric that I use to help figure out what on earth do I do with these potassiums. The easiest patients to manage are the ones who are at low risk of badness and have lower potassiums, meaning 5.5 to 6. You see this all the time. And probably the biggest risks are your patient's PCP sending, or nephrologist or whoever, sending them into the ED and making your ED crowded, or you doing too much to fix this and giving them hypoglycemia, because this is very unlikely to lead to problems. What about a patient who's still at relatively low risk, say they're end-stage kidney disease, and their potassium is high? Well, this is very, 6 to 6.5. And again, we'll say greater than 6.5, you'll do all the stuff. This is really common too, right? How often do you see these patients with 6.2 and their EKG is normal, they're at low risk to go into an arrhythmia, but you have to do something. And probably the biggest risk is to do nothing, or at least to fail to hand it off to somebody else as they get discharged. Your patients with very high potassium and high risk for arrhythmias, there you have to treat aggressively, right? That's kind of the no-brainer. Septic shock, kidney's not working, K is 6.3, you're going to do the stuff. The ones that scare me are the ones that come from other causes. And these are the ones where the K is not too high, but they are at high risk for something bad. And those are examples like acute cell death, rhabdomyolysis, where the K, it's only 5.7. Now, 4 hours later, it might be 7. Poisonings causing potassium shifting, and there the potassium is a marker of something very bad happening, like the hydrofluoric acid, or someone takes a lot of potassium chloride pills. These are uncommon scenarios, but if you hear about them, I would suggest you be worried about them, because that KCl, ingestion, sure, the K is 5.7 now. In 2 hours, it might be 9. I have seen that. Your patients with low risk and lower potassiums in end-stage kidney disease or ACE inhibitors, they'll probably be fine. The biggest thing is just making sure that somebody checks that K later. Your chronic hyperkalemia, chronic kidney disease, end-stage kidney disease, is one where you should probably work out something to do with a nephrologist. Do we give K binders? Do we do something else? We'll get to treatment in a little bit. And then your very high potassium with patient who's very ill, you're gonna, or has wide QRS changes, you're gonna do all the stuff. So let me give you your potassium story, right? Your ED is full of borders, and somebody presents with a K of 5.8 on outpatient labs, and they are, seeing you after they've been waiting for 8 hours, and their EKG, of course, is normal. So what do you do with these boxes? Um, if you have patients who have low risk hyperkalemia and the K is, say, less than 6, like this patient, you're not going to shift them. You might give them a potassium binder. You might give them a diuretic. And frankly, if they have a nephrologist, I would argue you might not have to do anything and just call the nephrologist and say, do we really need to do anything with this person? If most of the time it'd be a K binder if you do something. If you have patients with, say, a K of 6 or 6.5 and no EKG changes, once again, call your friendly nephrologist, see if they're dialysis, are you going to dialyze them here? Are you going to send them to their unit the same day? Or chronic kidney disease, are we going to manage them here? Or are we going to admit them and manage them longer? Or are we going to shift them or not? Those are individualized patient decisions, and usually, that's doesn't have to be decided in a minute because this patient isn't at super high risk. If your patient is at high risk, again, they've got something that's liberating potassium, septic shock, rhabdo, et cetera, you are going to shift them. You're going to give them calcium. You're going to give them definitive control, and you're going to admit them. And then lastly, if you have something like uh, a cardiac glycoside like digoxin, um, or something else that can cause rapid increase in potassium unexpectedly, you're going to shift them, you're going to watch them, and you're going to repeat that potassium, sooner rather than later. Even though the K is not very high right now, if it's a high risk thing, it's something that you should think about a little bit more. And these, again, are pretty uncommon. So I put emphasis on them because they're so uncommon, and we don't, we usually tend to treat them like these folks. Um, you all know how to treat potassium. So I'm going to go through this very quickly, maybe teach you a thing or two you didn't know about it, but you already know what to do, right? Even the third year medical students sitting here, in case there are anybody. Hello, third year medical students. I hope your EM rotation is going well. You're, you're going to give calcium to reduce your arrhythmias. You're going to give shifting agents to make the K down quickly, like insulin, and then you're going to give something through the kidneys, the guts, or dialyze through the blood to get rid of the potassium quickly. Uh, the way hypercalcemia works for hyperkalemia is that you'll remember you've got this threshold potential for activation. This is your cardiac conduction cycle. Sodium comes in, calcium maintains its depolarization, potassium goes out. Hyperkalemia increases your resting membrane. So you're more likely to hit that point at which you depolarize. So you are more likely to do something. And calcium pulls up your threshold potential to give you that less excitability, less likely to go into an arrhythmia. In general, that's good. Hooray for calcium. It also restores the slowed speed of conduction you get with hyperkalemia, where you get that wide QRS because normally you have this slowed speed of conduction. So calcium is going to make that faster too, to narrow your QRS a bit, restore some normal depolarization, maybe help that heart rate a bit. And then again, you get less bradycardia with some action of calcium on the SA node. So how do you get rid of potassium? Well, one is you can do shifting agents, right? So beta agonists and insulin work on your sodium potassium ATPase. Sodium bicarb gets potassium into the cell via the hydrogen potassium exchangers. These are things that you're familiar with. If you're giving patients insulin, how much glucose do you give? There's lots of different regimens that you can read, right? You can go to whatever reference you want, and you can find something that tells you definitively give this much insulin and this much glucose. And in general, it has rigorous data behind it. No, it doesn't. People just make them up. Sorry. There is one systematic review that I'll point to that basically says, all right, here's a variety of studies that give 10 to 20 units of insulin and give 25 to 60 grams of glucose. And it turns out the hypoglycemia is really only correlated with the glucose doses. And 20 units are not clearly better than 10, at least in this review. So what I do personally is I give 10 units of insulin and I give 50 plus grams of glucose, 2 amps of D50, or, the equivalent of D10 because everybody's out at D50. And if you're going to make up a regimen, in my mind, just try to make up the one least likely to hurt the patient, where we know that lower doses of glucose are correlated with hypoglycemia. So unless your patient's showing up with a glucose of 300, in which case your job is easy, you probably want to give them more glucose than you would think about to prevent that hypoglycemia as a result. Bicarb does not work well, by the way, in end-stage kidney disease. So if you have a patient with end-stage kidney disease and their K is 6.2, and you're like, well, I can't give diuretics, I'm going to give some bicarb, it probably isn't going to work. Give insulin glucose or give albuterol. And then there's only 3 ways to definitively get rid of potassium: diuretics, K binders, and dialysis. And your individual, I'm not going to go through these. We'll go through some of your binders. In terms of diuretics, loop diuretics are probably the fastest, but most of the time when people have hyperkalemia, their kidneys are not working well, so you're kind of not going to get a lot out of that. For digoxin and similar poisons, and I say similar, I mean a variety of plants like lily of the valley and yellow oleander. And maybe if you have a patient who is ingesting toad venom, your cane toads, your potassium is shifted because of blockade of the sodium potassium ATPase. This is a dose marker. It's kind of like a wide QRS in a TCA. The higher the potassium, the worse it is. And if you go back to older digoxin literature before the digoxin FAB, your Digifab or Digibind, if you had a potassium above 5.5, everyone died. And they died because of arrhythmias. And it wasn't because of the hyperkalemia. So K there should just cue you in. They've got a bad acute poisoning and we need to treat the bad acute poisoning. And the same is true in hydrofluoric acid poisoning. If you see one of these, be aware that they are very high risk for arrhythmias, and you should treat them very aggressively with calcium and magnesium. If I see another hydrofluoric acid poisoning, anytime soon, I'm honestly going to suggest that they notify the ECMO folks and say this person's at very, very high risk for arrhythmia. And then, we talk about things to bind potassium, but I think it's important to mention the low potassium diet. In my experience, the things that really get patients hyperkalemic are dairy, milk, and cheese. Vegetables have high potassium, but it's inconsistent. If you look at studies, you find that even patients with advanced kidney disease who follow vegetarian diets, without animal protein, you don't get as much potassium. And it's not fully understood why that is, because many animal protein sources, like beef and chicken, are not particularly high in K, but for whatever reason, it's correlated. I'll say this isn't 100% because I had a patient who followed a vegetarian diet. Her K was always between 6 and 7 in the outpatient setting. Like when we checked her monthly dialysis labs, I could not get it below 6. So there is some truth to potassium in your potatoes. And you don't have to make up these diet regimens to counsel patients. What I usually do is I ask them if they have access to the internet. If they do, I send them the National Kidney Foundation website, which has a ton of information. And if they don't, give them their local diet handout or print out the one from the NKF and give that to them. Diuretics won't fix potassium on a time scale that will help you figure out whether to dispo the patient. This will help them if they are getting admitted. All thiazide diuretics, loop diuretics, and actually giving bicarb will increase urinary potassium loss on a scale that is helpful to the patient who is being admitted, not so much the patient who you want to get the K better and send them home. Gut binders might fix it in the ED. K-exolate is the fastest one. You're the one that no one wants to give because there is a small but real choice of gut necrosis, chance of gut necrosis. Some patients don't have any other outpatient options than K-exolate because most insurance will make you pick this first. If your patient has commercial insurance, you can usually get away with one of your gut binders. But bear in mind, you might give them a prescription for these from the ED, and they might not be able to get it because it often requires a prior authorization. patiromer is not helpful to you in the ED. It will lower it over days. The manufacturer says it's faster. Most studies say it's slower, so I would probably not pick this one unless that's what you've got. Lokelma, a little bit faster, lowers over 4 hours. Every single one of these binds drugs, so don't give them with any medications at the same time. What do you need to worry about with gut binders? They bind medications. KX-like can cause gut necrosis, and it's entirely possible the other two can. We don't know. They haven't been around long enough. If you give a patient a potassium binder and they leave and you give them a prescription, they really need follow-up, right? Because the reason they had hyperkalemia is almost certainly still present. And just be aware that many need a prior authorization. Tell the patient that, make sure that they're going to call their primary doctor and or their nephrologist and follow up. Also, people don't like the way they taste. I can dialyze your K from 7 to 4 in an hour, and I shouldn't, because when we dialyze patients very quickly, we actually increase their risk for arrhythmias. So, in general, your patients with scary hyperkalemia, probably need to be admitted and dialyzed because they're going to get dialysis. And if it's done right, they're not going to remove that much potassium at first, and their K will be higher, and they're going to need dialysis the next day. If your patient has moderate hyperkalemia, that you can sometimes work out with your nephrologist to get to the outpatient dialysis unit if they haven't missed their chair time, which in my experience, usually they do. So lastly, what do? If your risk is low and your potassium is not very high, you use, in general, potassium binders, diuretics. If you're not planning on repeating the potassium, maybe nothing. You call nephrology when your K is high and such. I've already shown you this, and I would encourage you to just look at this if it's useful to you, in the slides. And then lastly, what do you do with the scariest patients you're going to see? Somebody has trauma, induced rhabdo or fentanyl-induced rhabdo where they're found down after 24 hours, or tumor lysis, or profound ischemia, and their potassium's rising very quickly. Give calcium, give insulin, consider a bicarb drip, and get them on dialysis soon. Call your nephrologist early when their potassium is rising very quickly. And do bear in mind that every once in a while you will have a patient on several pressors. This is more for your ICU rotation, not in your ED. I hope they're not in your ED for that long. Where if you put them on dialysis and their potassium still rising, that may not be a reversible process. And sometimes that prompts some tough conversations. Just a few last thoughts. Treat your potassium as above 6.5. Treat your major EKG changes. Chronic hyperkalemia, do something, but maybe that something is to set them up with follow-up. Acute hyperkalemia, do something acute, watch them longer, look for things that need treatment besides potassium. Remember that you can make people hypoglycemic with insulin, and your nephrologists, local nephrologists are your friends. We like this stuff. We like to be called. And that's all I got. Happy to take any questions in the minute or two remaining.